Selamat siang. So my name is David Katz. I'm an epidemiologist at the University of Washington in the Department of Global Health, and also as an work as an HIV testing services consultant for WHO. And so I've been asked to give an overview of partner notification services, and so I'll start with just how it works, and then talk about WHO guidelines, and then some implementation considerations. So this slide here shows kind of the process of how partner notification services work. It's a voluntary process by which a trained provider asks people diagnosed with HIV about their sexual and drug injecting partners. And then if the client consents, offers to assist in notifying the partners of their potential exposure, as well as offering HIV testing and linkage to prevention and care. And so the objective here is really to increase testing among partners of people living with HIV, and link them to prevention and care services. So partner notification has really been a long-standing component of infectious disease management for many infections, including for tuberculosis and bacterial STIs. Until the last decade, partner notification for HIV was really focused specifically in, it was limited to some high-income countries, including Australia and the US, but increasing evidence of its safety and effectiveness, particularly coming out of sub-Saharan Africa, led WHO to release guidelines around partner notification and subsequent global scale-up. So the rationale here is that sexual and drug injecting partners of people living with HIV have an increased likelihood of being HIV positive or at high risk for HIV acquisition and may not be aware of their potential exposure or infection. As a result, that means that partner notification really presents an important opportunity for high-yield HIV case finding, as well as an opportunity to link partners to HIV prevention and treatment. Therefore, partner notification can really help us achieve the 90-90 and 90 objectives and ultimately decrease HIV transmission, morbidity, and mortality. So there are several options that providers can discuss with clients for notifying their partners. The three on the top here are considered assisted approaches, where the provider really assists the client in notifying their partners. So this is, for the first of these are provider referral, which involves the healthcare provider calling or visiting their partners to notify them of exposure and offering testing. Contract referral, where the client agrees to notify their partner within a specific time period, after which the provider will contact the partners with the client's permission. Is it not working? Can you hear me?
Yes.
Okay.
Just closer.
Oh, just closer. Okay.
Yeah.
I talk with my hands, so sometimes. Oh, there we go. It's I try not to. I don't know how to use a microphone. Okay. So and then dual referral, where clients and providers will notify their partners together, and clients can also, of course, choose to notify their partners themselves, and encourage them to get tested. This is considered client referral. And from the perspective of the health department or the health system, this is a passive approach, and it's generally considered less effective. So, what does WHO recommend and why? From a systematic review of partner notification services, the key evidence showed that assisted strategies increase HIV testing uptake and linkage to care among partners of people living with HIV. That assisted partner notification services and all partner notification approaches result in high test positivity or yield, and then that they're safe. These approaches are safe. Social harm and other adverse events were very rare in trials and in programs. And this led WHO to recommend that voluntary assisted partner notification services be offered as part of a comprehensive package of testing and care offered to people with HIV. So WHO and PEPFAR have laid out some key principles of partner notification services. That these services be client-centered and client-focused. It's really focused on the needs of both the clients and their partners. That partner services be confidential, voluntary and non-coercive, that referrals to prevention and care are integrated into the programs, that they be non-judgmental and culturally and linguistically appropriate, and that they be free and accessible and available to everyone. So some important considerations for implementation. How these services are implemented can vary by provider type, setting, and population. That voluntariness and confidentiality are really paramount. Notification should be made only to partners and the anonymity of the index client should be maintained if they desire that. And that criminal justice, law enforcement, and non-health personnel should not be involved in these services. The services should be offered periodically. That means throughout the, after their first diagnosis and then throughout the course of HIV treatment and care. That's because people's situations and partnerships change, as well as their readiness to consent to partner notification or share their status with their partners. And another that, in terms of this client-centered and client-focused approach, that preferred notification approaches, as well as contact methods, vary by context, individual, and partnerships. So the WHO guidelines also outline some key potential challenges. First, that laws or policies that stigmatize, criminalize, or discriminate against key populations or people living with HIV can really complicate the delivery and monitoring of partner notification, particularly with respect to an increased reluctance to participate in partner notification among these populations. And also that eliciting, locating, and notifying partners can be challenging. It requires well-trained providers and can be require a significant investment in human resources and in terms of the effort required to do this work. These activities really can be affected by relationship dynamics within partnerships, which are obviously can be complicated, and that these activities may be especially challenging for non-primary and casual partners or for mobile, vulnerable, and key populations. So partner notification and index testing often get discussed sort of in the same breath. They're both index-based approaches to increasing HIV case finding. And so I just wanted to point out a couple of different differences in the definitions, at least in the definitions, if not in how they actually become implemented. So in partner notification, just two things. One, the primary focus is on sexual or drug injecting partners, whereas in index testing, you may expand to a broader set of contacts, which might include children or other household members. And then in partner notification, there's really an emphasis and promotion of notifying the named contacts about their potential exposure, as well as, and then offering HIV testing, whereas index testing may only involve offering the HIV test alone. And just to think that both of these can be implemented in either community or facility settings, and how we talk about them and the terminology we use may actually affect uptake. And finally, just to leave you kind of where we are globally, this is from an ongoing review of the uptake of assisted partner notification and index testing policies by region of the world. And what you see is that the uptake of these policies have been increasing over the last couple of years, but there's still many countries left without policies. And in the Southeast Asian region, which includes Indonesia, only 6 of the 11 countries have index testing or partner notification policy as of, I guess this is of last year, so maybe there are more now. So with that, I just want to acknowledge my WHO colleagues, and especially Cheryl Johnson at headquarters, and Tiara Nisai, who's really instrumental in getting me here, and I'm looking forward to working with her on partner notification implementation here in Indonesia, and leave you with some resources that may be of use. Terima kasih.